We'll get started. So good morning. Welcome to Cardiac Sciences Grand Rounds today. It's a great pleasure to have Dr. O'Neill with us today. Dr. O'Neill completed her medical school internal medicine and cardiology training at the University of Alberta, and she got recruited back there as an assistant professor in the Department of Medicine, Division of Cardiology. She developed an interest in risk stratification and optimization of care for older adults, and subsequently went to University of Pittsburgh Medical Center and completed a fellowship in geriatric cardiology with additional training in palliative care cardiology. She's a staff cardiologist and, as mentioned, assistant professor at the University of Alberta Hospital. Her clinical and research focus is on risk stratification of older adults prior to procedures such as TAVI, CABG, and surgical valve replacement, frailty and comprehensive assessment of complex older adults with cardiovascular disease. And she also has a very great interest management of atrial fibrillation in the elderly and the frail. So thank you, Dr. O'Neill. It's a great pleasure to have you with us today.
Thank you so much. So I will just get my screen shared with you all. All right, so thank you again for the invitation and for that kind introduction. So today I am going to talk about a topic that's near and dear to my heart, some of the important considerations and nuances in prescribing oral anticoagulation in older adults with atrial fibrillation. This is my only disclosure. So what I hope to cover today is we'll start with data that is from landmark and real world trials, but really focusing specifically on the data in older adults. This can be pre-specified analyses, post hoc data, and some post analyses that have been done, because as you're all aware, a lot of our older adults aren't really the first and foremost included patients in our randomized controlled trials. We'll then move on to the more sparse evidence for oral anticoagulation in various common geriatric conditions. And then we'll finish up with what to do with oral anticoagulation unsuitable patients. So this is the case. This is a case of an older lady that I saw in cardiology wards. She's 89. She only speaks Polish. She has atrial fibrillation on warfarin, hypertension, type 2 diabetes, HFpEF, chronic kidney disease, mild cognitive impairment, osteoporosis, and osteoarthritis. She walks with a walker, and she lives with her son and her daughter-in-law. She does all of her own BADL. So those are things like washing yourself, cleaning yourself, toileting yourself, feeding yourself. In terms of her IADLs, she can use the telephone, she can sweep and vacuum, but everything else she's at least partially dependent. So things like shopping, finances, things of that nature. She presents to the emergency department with syncope and a fall, and she's found to have a moderate to large size subdural hematoma. Her warfarin is stopped, vitamin K and PCC are given, neurosurgery is consulted, and thankfully it's deemed to be appropriate for conservative management, so she's admitted to cardiology. While she's admitted, she's persistently bradycardic, and she does have multiple sinus pauses, the longest of which is about 5 seconds. And she does have pre-syncope associated with each sinus pause that she describes as being quite typical to what she was experiencing pre-hospitalization. So a pacemaker was inserted. The patient's son is always at the bedside. He translates for her and for us, and he assists her also with making her medical decisions. And the son tells me when I take over on the wards that it has already been decided with the previous cardiologist not to restart anticoagulation due to her fall and her subdural hematoma. So just an introduction, things I'm sure you're all aware here, but atrial fibrillation is the most common sustained arrhythmia worldwide. And this prevalence is only increasing with our aging population. If we look here, it's estimated that about 16 million Americans will be affected with atrial fibrillation by 2050 because of this really tsunami of aging population. Atrial fibrillation is important because it impacts outcome. It's associated with a 1.5 to 4-fold increased risk of mortality, a 3 to 5-fold increased risk of stroke. And currently it's estimated that atrial fibrillation still accounts for 1 in 5 strokes in Canada. And these strokes are more severe with higher morbidity and mortality than non-atrial fibrillation related strokes. We all know that according to our Canadian cardiovascular guidelines, everyone 65 and above without contraindication should be on oral anticoagulation. We know that oral anticoagulation can decrease the risk of stroke by over 60%. But also what we know from literature is that only about 40 to 60% of eligible older adults actually receive it. And I think this is often due to the complexity of that treatment decision in older adults. So again, just a bit of background that I'm sure you all here are aware of, but we all started with warfarin with our oral anticoagulation, interfering with factors 2, 7, 9, and 10, protein C and S, widely available, inexpensive. Physicians have a lot of experience dealing with warfarin-related bleeding, so have become a lot more comfortable with it. However, it has a narrow therapeutic index, multiple food and drug interactions, and this led to the development of our DOACS. The DOACS target specific steps in the coagulation cascade, namely factor 10A and thrombin. They're highly efficacious, have a good safety profile, fast onset, short half-life, wide therapeutic window. They don't require laboratory monitoring. And all of this has led to the recommendation now and for some time now for DOACS over warfarin in the majority of adults with non-valvular atrial fibrillation. So as I said, we're not going to touch on the landmark trials as a whole, but instead some of the pre-specified and post-hoc analyses specific to older adults. So Eckelblum and colleagues reanalyzed the RELY trial, which was the landmark trial on dabigatran, looking at the risk of bleeding on dabigatran versus warfarin by age. And they actually found a significant treatment by age interaction. If you look here on the dabigatran 110 milligrams BID dose, significantly less bleeding on dabigatran versus warfarin in those less than 65, as well as those 65 to 74. However, when you look at those 75 and above, really no difference in major bleeding between dabigatran and warfarin. When we look at standard dabigatran dosing, 150 milligrams BID, yet again, we see statistically significantly less bleeding in those less than 65, as well as those 65 to 74. But now when we look at our population of age 75 and above, there's actually a trend towards higher risk of major bleeding with dabigatran versus warfarin. So this is actually what led to our current guidelines where we dose reduce to dabigatran 110 milligrams. And anyone 80 and above or 75 with additional bleeding risk factors. I will point out what is not seen here is that the risk of intracranial hemorrhage was consistently reduced in any age group, as well as with both doses of dabigatran. Moving on to RIVAROXABAN, the landmark trial supporting its use was ROCKET-AF, and this trial was also reanalyzed, looking specifically at the safety and efficacy of RIVAROXABAN in older adults aged 75 and above. And as you can see, really comparable rates of stroke systemic embolism on the two drugs, comparable major bleeding. So the overall takeaway was that efficacy and safety of RIVAROXABAN was maintained irrespective of age. Moving on to apixaban. So the landmark trial supporting its use was Aristotle. This trial was also reanalyzed, looking at safety and efficacy of apixaban versus warfarin, this time dividing the age groups into those less than 65, those 65 to 74, and those above and equal to 75 years of age. Not surprisingly, event rates were highest in the oldest old. Stroke, systemic embolism, all-cause death, major bleeding. However, apixaban was more effective than warfarin at preventing stroke, systemic embolism, and reducing mortality across all age groups. It was also associated with less major bleeding, less total bleeding, and less intracranial hemorrhage regardless of age. So not only was safety and efficacy of apixaban maintained across all age groups, but because of the highest event rates in our oldest old, the absolute benefit of apixaban was actually greatest in the oldest old age group. Moving on to EDOXABAN, Engage AF TIMI 48 was the landmark trial supporting its use. A pre-specified analysis of this trial was performed by Cato and colleagues, looking at safety and efficacy of EDOXABAN in older adults. As you can see right here, stroke systemic embolism rates were really similar between EDOXABAN and warfarin, but trending towards superiority for EDOXABAN in the oldest old age group. When we look at major bleeding, superiority for EDOXABAN in both the age groups of 65 to 74, as well as those 75 and above, with this confidence interval just stopping shy of the line of unity there. And when we look at intracranial hemorrhage rates, once again, our two oldest age groups are clearly seeing superior rates of intracranial hemorrhage with EDOXABAN compared to warfarin. So EDOXABAN as well shown to retain efficacy and safety, perhaps even more safe in older adults. So I'm sure, again, you're all aware, but there have been no randomized controlled trials competing DOAC to DOAC. So this is a network meta-analysis of those landmark DOAC trials I just spoke about, evaluating efficacy and safety of DOACs as a whole compared to warfarin, as well as DOACs compared to DOACs, all specifically in patients 75 years and above. Overall, DOACs were shown to reduce stroke systemic embolism by 24% compared to warfarin. They were shown to reduce intracranial hemorrhage by 62% compared to warfarin, with no significant difference in bleeding. When compared to each other, in terms of stroke systemic embolism prevention, apixaban and dabigatran, 150 milligrams BID, came out on top as superior. When we look at the rates of major bleeding, it was apixaban and EDOXABAN 60 that really had the lowest rates of major bleeding. And when we looked at intracranial hemorrhage rates, all of the DOACs are found to be superior compared to warfarin, with the exception of RIVAROXABAN. So I think in review, we can say DOACs are at least as effective as warfarin for stroke prevention in older adults. They are at least as safe as warfarin in terms of major bleeding, with some actually trending towards or being safer. However, we know that the older adults we all see in clinical practice are not always the same as those represented in our clinical trials. So let's talk about some of the real world trials to see whether the efficacy and safety of these drugs are really panning out in observational trials. Firstly, we'll start with the Aristophanes trial. This was an observational propensity matched trial looking at the rates of stroke, systemic embolism, and major bleeding on apixaban, RIVAROXABAN, dabigatran, and warfarin. There were over 400,000 patients included, and over 78,000 were 80 and above. And this is the subgroup analysis by age. So as you can see, in terms of stroke and major bleeding, apixaban really did well, both safe and effective. When we move on to dabigatran, not quite as strong data, trends toward efficacy and statistical significance in the 80 and above in terms of being superior to warfarin in stroke prevention. Again, trends toward safety in terms of major bleeding in that 80 and above age group, but statistical significance in the 75 to 79. However, where I really want you to focus is RIVAROXABAN. So definitely effective. It's superior to warfarin in terms of stroke prevention. But when we look at the rates of major bleeding, trend towards increase in major bleeding in those 75 to 79, and really significantly more major bleeding on RIVAROXABAN versus warfarin in those 80 and above. Similar trial here, another observational trial looking at safety and efficacy of apixaban, rivaroxaban, dabigatran, and warfarin, this time ages 65 and above with both atrial fibrillation and heart failure. Once again, apixaban does well, superior in terms of stroke, major bleeding, and MACE versus warfarin. Dabigatran has superiority to warfarin in terms of MACE. Rivaroxaban does well in terms of stroke as well as MACE. But once again, pointing out here, statistically more major bleeding with rivaroxaban versus warfarin. When DOACS were compared in this trial, apixaban really came out on top, being superior to dabigatran and rivaroxaban in both major bleeding and MACE. So the conclusion of this trial was really in older adults, apixaban came out on top. This is a retrospective cohort study, Medicare beneficiaries, so they're all 65 years and above. They have atrial fibrillation, and they were looking specifically at those prescribed rivaroxaban and apixaban, followed for about 4 years. Numerous patients included, as you can see, mean age 77, and the primary composite was of major ischemic outcomes, stroke, systemic embolism, as well as hemorrhagic outcomes, hemorrhagic stroke, other intracranial hemorrhage, fatal extracranial hemorrhage. And as you can see, this primary outcome occurred significantly more often in rivaroxaban, with that curve separating early around 3 months and really maintaining separation throughout time. And of note, all of the subcomponents were significantly worse with rivaroxaban as compared to apixaban. So just because none of these observational trials included EDOXABAN, being the latest to market DOAC, I did want to mention just one real world trial of EDOXABAN. This is the Aetna AF Europe trial, a post-authorization multi-center prospective observational trial meant to assess safety and efficacy of EDOXABAN. Over 27,000 patients have been included, and they have purposely included some of the oldest old, with 50% of their population being 75 and above, 11% being 85 and above, and they've also analyzed frailty in all patients. The first graph up here is 1-year follow-up data, really focusing on the event rates in terms of stroke and major bleeding on EDOXABAN. If we look at the purple, this is age 80 and above, so very high risk subgroup, and event rates for stroke quite reasonable at 1.22% per year. This is an even higher risk subgroup, the frail population, also event rates quite acceptable, less than 2% per year of stroke. Moving on to major bleeding, similar trends are found, quite acceptable rates even in our highest risk subgroup of those over 80 and those frail. The 2-year event rates also look similar, just recently published, looking at all of the major events, all being more frequent in the oldest old age group, not surprisingly, but really these are the event rates per year, so 2%. All of these are occurring less than 2% per year. So it does look like even in the real world, EDOXABAN is doing well in terms of safety and efficacy in older adult populations, even with high risk features like frailty. So if I'm telling you that there is such reasonable data, although it's not the highest quality, why are there such low rates of prescription in older adults of oral anticoagulation? Well, some of the common physician-cited reasons in the literature are just old age in itself, cognitive impairment, and fear of bleeding. And this is a complex treatment decision. As the risk of stroke increases with age, the risk of major bleeding really skyrockets with age. And it's really difficult to weigh this risk and balance of stroke and bleeding. Now, I present these not because we use the CHADS2 VASC score often in Canada, but just because there are more variables here, and just to really show that there is a lot of overlap in our stroke risk factors and our bleeding risk factors. So oftentimes, especially in our older adults, if our patients are at high risk of stroke, they're also at high risk of bleeding. And it's really difficult to balance which one is more important than the other. Additionally, there are a lot of geriatric conditions that are not included in these risk scores and that are very relevant in prescribing these drugs. So if we look at our lady like case Mrs. P, she had a CHADS-2 VASC score of 6, which would give her a 9.7% per year risk of stroke. She has a Hasbled score of 4, which would give her an 8.9% per year risk of bleed. Both of these are quite similar. Both of these are high. Really difficult to say which one is more important than the other. Additionally, these are the important things that are not included in the score that we're going to go into in the coming slides. All right, so what is the evidence for oral anticoagulation in our patients with polypharmacy? So polypharmacy is most often defined as being on 5 or more medications. It's quite common in our older adults, and it's associated with a lot of adverse outcomes: decreased quality of life, increased falls, increased adverse drug events, increased hospitalizations and healthcare expenditures, as well as mortality. A reanalysis of the AFFIRM trial found that polypharmacy conferred a 30% excess relative risk for cardiovascular death in atrial fibrillation patients. Now, there has been a reanalysis of the ROCKET AF trial looking specifically at polypharmacy. They found polypharmacy was present in about 2/3 of patients, and these patients did have increased risk of MACE and clinically relevant bleeding. However, there was no difference in the primary efficacy or safety of RIVAROXABAN in those with polypharmacy. I will note, however, that when they pulled out only the patients on 0 to 4 medications, there was a lower rate of major bleeding in these patients. So it does suggest that there is some increase in bleeding associated with polypharmacy. Moving on to this post-hoc analysis of Aristotle, polypharmacy was actually present in over 3/4 of patients in this trial, again associated with risk, having increased risk of stroke, bleeding, and mortality. But the efficacy of apixaban was maintained, albeit there was a smaller reduction in major bleeding with apixaban versus warfarin in the polypharmacy group. And lastly, this systematic review and meta-analysis, again, showing polypharmacy in atrial fibrillation is very, very common. It is associated with adverse outcome, with all-cause death, hospitalizations, reduced quality of life, and major bleeding, but there is no association between polypharmacy and oral anticoagulation efficacy, nor is there an impact on intracranial hemorrhage rates. So I think overall, think of polypharmacy as a marker of risk. It may be because of the polypharmacy itself. It may be because of the comorbidities that the patient has to cause the polypharmacy, but they do have a higher risk of stroke, bleeding, and mortality. But do remember that DOACS have evidence for retained efficacy and safety, although there is some increase in bleeding risk with retained intracranial hemorrhage rates. Moving on to frailty. Frailty is defined as an increased vulnerability to physiologic stressors, and it's related to a decline in physiologic reserve. It's thought of more of biologic age rather than chronologic age, and there's been a lot of awareness about frailty over the past decade or more, just because of its association with adverse outcomes, disability, morbidity, and mortality. Older adults with atrial fibrillation are 4 times more likely to be frail than older adults without atrial fibrillation. And frailty is quite relevant because it's a commonly cited reason for why people do not prescribe oral anticoagulation. So there has been a post-hoc analysis of the ENGAGE-AF-TIMI-48 trial of EDOXABAN looking at frailty. They determined that 20% of the population of this trial was frail by the cumulative deficits model. And as frailty increased, the risk of stroke and major bleeding increased sequentially. EDOXABAN efficacy and safety were unaffected by frailty, with lower bleeding risk than warfarin in all patients, with the exception of those with the most severe frailty. This second trial that I mentioned here was more recently published, a cohort study looking at Medicare beneficiaries, so again, 65 years and above with atrial fibrillation, looking at the incidence of all-cause death, ischemic stroke, and major bleeding, by oral anticoagulation, but also by frailty status. So if we look here, this is DABIGATRAN versus WARFARIN in the non-frail, pre-frail, and frail. This is RIVAROXABAN versus WARFARIN in the non-frail, pre-frail, and frail. And this is apixaban versus WARFARIN in the non-frail, pre-frail, and frail. WARFARIN is shown in the dark line, and the DOAC is shown in the lighter line. And as you can see, it's really only apixaban that reduced the primary endpoint at all frailty levels. DABIGATRAN and RIVAROXABAN only reduced the primary endpoint in the non-frail population. So I think frailty is probably the best marker that we have at current of increased risk in older adults. They are at increased risk of stroke, bleeding, and mortality, and that is even before you prescribe them a DOAC. But apixaban and EDOXABAN do have evidence for retained efficacy and safety in frailty. However, I will caution use in DOAC in the more advanced severe frailty group. They do have such a high risk of bleeding and competing mortality risks that that risk-benefit ratio can really tip in terms of trending towards wanting to be more safe in these patients rather than more effective. Moving into multimorbidity, so actually defined as only having 2 or more chronic medical conditions, but associated with very poor health outcomes. The UK Biobank study showed that atrial fibrillation patients had a 6-fold morbidity.
We're losing you there, Dr. O'Neill.
Let me see. 1 second. Let's see what we can do.
I can't hear you now. Nope. We were hearing you well, but the connection was kind of flaky. Still not hearing you. Probably a multimorbidity issue. Maybe you go back on your AirPods, it's gonna work. Still no sound, sorry.
All right, how are we now?
Yep, we can hear you.
Perfect, excellent. Sorry about that. So what I was saying was just that our research practice and clinical practice guidelines really have excluded multimorbidity. And when we look at our Get With the Guidelines atrial fibrillation registry, they actually found the higher the multimorbidity burden, the lower the odds of oral anticoagulation prescription. And I don't think that's surprising. If these people are not represented in our clinical practice guidelines, it makes the decision really difficult in knowing what to do with them. So there has been a post hoc analysis of both the Aristotle and Engage AF TIMI 48 trial on multimorbidity. Both of these have shown that multimorbidity is a marker of risk, increased risk of stroke, systemic embolism, death, and major bleeding, but efficacy and safety of both apixaban and edoxaban have shown to be preserved independent of the degree of multimorbidity. So again, this is just another marker of increased risk of stroke, bleeding, and mortality. And once again, it's apixaban and edoxaban have the greatest evidence for preserved efficacy and safety. Moving into falls. So the risk of falls increases with age. 1 in 3 adults 65 and above, nearly 50% of those 80 and above have at least one fall a year. Falls are not a contraindication to oral anticoagulation, but I do think we, when we are prescribing oral anticoagulation, should at least assess fall risk and think about whether it could be modified. So that may be by way of deprescribing fall increasing drugs, thinking about having them assessed for hearing or visual aids, having an OT come in for a home safety assessment or mobility aids, etc. We do know that falls on oral anticoagulation predispose to intracranial hemorrhage. However, the absolute risk of intracranial hemorrhage with a fall is generally lower than the risk of stroke in most of our older adults with atrial fibrillation. And DOACS are associated with not only a lower risk of intracranial hemorrhage, but also a lower risk of traumatic intracranial hemorrhage. So some of you may have heard of this Markov decision model, kind of more infamous in the internal medicine world, looking at the impact of falls on bleeding risk on warfarin rather than DOAC. They found that the highest quality adjusted life expectancy was with warfarin as opposed to aspirin or no agent at all, regardless of the annual fall risk, altering it anywhere from 0% to 100%. And they actually estimated that an older adult would need to fall about 300 times per year to offset this benefit. There has been a post hoc analysis of Aristotle in fall risk patients, showing these fall risk patients are at higher risk of major bleeding, intracranial hemorrhage, and mortality. But apixaban was not only efficacious and safe, but it was found to be associated with a 80% reduction in intracranial hemorrhage rates versus warfarin. Pre-specified analysis of ENGAGE AF-TIMI 48 also done on high fall risk patients. Higher fall risk patients, of course, at higher risk of fracture, major bleeding, life-threatening bleeding, and mortality. But again, EDOXABAN maintained its safety and its efficacy with a greater absolute risk reduction in bleeding and mortality versus warfarin. So again, not a contraindication. You could use warfarin or DOACS in this patient population, but I would prefer DOACS because of that decreased risk of traumatic intracranial hemorrhage risk. And if we're looking at where the best evidence lies thus far, apixaban and EDOXABAN really are the best studied in this area. Now let's talk about cognitive impairment. So atrial fibrillation is independently associated with cognitive impairment. There are several proposed mechanisms. It may be silent cerebral microinfarcts or beat to beat variability causing some hypoperfusion. But regardless, you are going to see these two things coming in pairs more often than not. And the identification of cognitive impairment is important. These patients with cognitive impairment do have an increased risk of falls and therefore intracranial hemorrhage risk, but they also have an increased risk of medication non-adherence. So I do encourage my colleagues, whether they listen to me or not, to consider doing just a very brief cognitive screen. So this is the mini cog. It takes less than 3 minutes. You give a patient 3 words, you ask them to remember them, you get them to draw a clock, and then you get them to recall those 3 words. If they can recall 0, they screen positive for dementia. If they can recall all 3 words, they do not have dementia. And if they can recall 1 to 2, then you move to the clock being normal or abnormal to see whether they screen positive. Now, what would I do with this information? You can refer them to a geriatric specialist or back to their general practitioner with this additional information. But it is important because, like I said, it could impact outcome in atrial fibrillation with medication non-adherence and intracranial hemorrhage risk. Now, we know medication adherence does require multiple cognitive domains. So it is not only people with dementia that are impacted by this, even just mild cognitive impairment can have issues with medication adherence. And there are actually reported rates of non-adherence as high as 50% in community dwelling older adults. So DOACS, as we know, are taken at fixed dosages. We don't need to monitor them, and that can improve adherence and persistence. But literature also suggests dosing regimen, daily versus twice daily, can also impact adherence. So our 4 DOACs all have similar half-lives, and our dosing regimens do differ. The once daily drugs, as we know, are EDOXABAN and RIVAROXABAN. The twice daily drugs are DABIGATRAN and APIXABAN. This is a cohort study not specifically in older adults of over 18,000 adults with atrial fibrillation, and 1/3 of patients on oral anticoagulation were shown to be suboptimally adherent. And they did show that once daily dosed DOAC was associated with an improved compliance rate compared to twice daily dosed DOAC. Not surprisingly, the risk of stroke increased with suboptimal adherence, but this is also interesting. So some physicians will prescribe a twice daily dose DOAC, thinking that it's more forgiving if a patient were to miss one single dose than a once daily dose DOAC, but that did not pan out. So the hazard ratio for stroke was about 1.5 times. Regardless of whether you're on a once or twice daily dosed DOAC. So if you're worried about medication compliance, don't prescribe a patient a twice daily dose drug thinking it's more forgiving. Perhaps lean towards prescribing a once daily dose drug because it can make compliance improved. So now let's shift gears and talk about our oral anticoagulation unsuitable patients. Firstly, I wanted to start with what does not make them unsuitable. So after a bleeding event, about 1/2 of atrial fibrillation patients are never restarted on oral anticoagulation. And there are several large observational trials and meta-analysis data that supports restarting oral anticoagulation after a major bleeding event or even after an intracranial hemorrhage in most patients. It's associated with a decreased risk of thromboembolism, not surprisingly, but also a decreased mortality risk without an increased risk of recurrent intracranial hemorrhage. There is some data that suggests a trend towards increased risk of major extracranial hemorrhage in patients who have had a previous bleed, but the net clinical benefit still favors restarting oral anticoagulation. This is just one of such trials looking at a population of atrial fibrillation patients who had an intracranial hemorrhage who were either not restarted on oral anticoagulation or restarted. And as you can see, ischemic events obviously quite low in comparison with the oral anticoagulation resumption group, but hemorrhagic events really not significantly different between the two groups. And our Kaplan-Meier survival curves really quite low survival compared to the no oral anticoagulation resumption, or quite low mortality, pardon me, in the oral anticoagulation resumption group compared to the no oral anticoagulation resumption. So the only thing I will preface that all with is that it really does depend on the type of intracranial hemorrhage. So a spontaneous lobar intracranial hemorrhage that is thought to be from cerebral amyloid angiopathy, something that happens tendency in our older adults, does have evidence of increased recurrence risk. This is best diagnosed with MRI brain in T2 weighted images. And if a patient is shown to have 5 or more microbleeds, then that is where the literature really starts to show that there is an alteration in risk benefit of oral anticoagulation restart. And literature would suggest consideration of alternatives in those patients, like a left atrial appendage occlusion device. So we all know GI bleeding would be more common than an intracranial bleeding event, and these are rarely fatal, but I do want to point out these are often associated with a cascade of events in our older adults that really can result in declining function, morbidity, mortality, even loss of independence. So when we make these decisions, even though there's good evidence to restart oral anticoagulation, we really need to weigh individual risks and benefits, individual values and preferences in a process of shared decision making. So if you do decide to not prescribe oral anticoagulation, I don't think I need to say this to this population, but I would be remiss if I excluded it. I think just to mention, we do not prescribe ASA instead. Avaros trial, over a decade old now, 5,500 patients that were deemed unsuitable for warfarin, randomized to apixaban and aspirin. And actually the study terminated early due to the clear superiority of apixaban over aspirin in terms of stroke and systemic embolism prevention, and no significant increase in major bleeding rates. There has been a subgroup analysis of this trial based upon age, and same data really showing in the greater than 75 age group, with really just a greater benefit of apixaban seen in stroke systemic embolism prevention, and no difference in major bleeding. The other thing I would encourage you not to do would be to off-label dose reduce your DOACS. So the Orbit AF2 national observational trial of atrial fibrillation patients on DOACS, about 1 in 6 patients were treated with reduced dose DOAC, despite only 43% meeting an indication for dose reduction. And this off-label dose reduction was associated with increased cardiovascular hospitalization with no decrease in bleeding. This case control study, 37 stroke units, looked at just over 700 patients with atrial fibrillation on a DOAC presenting with stroke, comparing them to 700 patients with atrial fibrillation on a DOAC and who did not have a stroke. And the off-label dose reduction of DOAC was associated with a 3-fold increased risk of stroke. Lastly, this retrospective analysis, almost 15,000 patients with atrial fibrillation, 13.3% inappropriately underdosed. And it was apixaban that really came out as associated with a 5-fold increased risk of stroke when it was inappropriately dose reduced, with no significant difference in bleeding. So if you're going to treat your patient with a DOAC, treat them with the proper dose. You're really not doing them a benefit by inappropriately underdosing. Now, in saying that, many people may have heard of this elder care trial, and I just wanted to speak about it briefly and touch on where I think it could be useful in our clinical practice. So the elder care AF trial was a double-blind, placebo-controlled trial of EDOXABAN 15 milligrams daily. Remember, normal dose of EDOXABAN is 60, reduced dose is 30 milligrams daily. So this is a new dose of EDOXABAN. It's in Japanese patients 80 and above with non-valvular atrial fibrillation who are deemed to be unsuitable for oral anticoagulation. A lot of reasons why they deemed them unsuitable. We won't get into that today, but there was a significant reduction in stroke with this EDOXABAN dose and no significant increase in major bleeding, with the exception of GI bleeding. So why was this different? Why am I telling you don't inappropriately dose reduce your DOAC, but this worked? Well, this was a different population. They were quite a bit older. Their mean age was 86.6 versus in the 70s for other trials. They had quite low body weight, only 50 kilograms median, and they were all of Asian descent, which is not typical of our classic North American European trials. This was a drug versus placebo trial, so it's not reduced dose DOAC versus full dose DOAC, and it does make sense that some amount of DOAC would be better than none at all, but this really does show you this is in truly oral anticoagulation unsuitable patients. I wonder about sarcopenia. This is an oldest old age group, low body weight, and DOACs are hydrophilic. So it could be that there are supratherapeutic DOAC levels at play. And I also wonder about genetics. These were all Japanese descent participants, and Japan does have a lower INR target as well as a lower RIVAROXABAN dose. So there could be a genetic play here. But how do I think we can apply it? I think I emphasize again, do not off-label underdose DOACs. This was not that in this case. This was a trial of a new dose in unsuitable for oral anticoagulation patients. And don't think about EDOXABAN 15 as an alternative to another DOAC. If you're considering an alternative, use it. In fact, the 15 milligram dose is not approved by Health Canada for oral anticoagulation stroke prevention in atrial fibrillation. But if you have a patient who is otherwise unsuitable for oral anticoagulation, you would have them on nothing otherwise, this is where I do consider using the dose EDOXABAN 15 milligrams daily. So perhaps they've had a life-threatening bleed, high frailty, low body weight. This is when I think of it. The last thing I do think about, and even though we don't do them in Edmonton, unfortunately, this is something we would use in the US when we had such a case. We think about percutaneous left atrial appendage occlusion. So this is our Watchman device, and it has emerged as an alternative to long-term oral anticoagulation in those who can tolerate short-term oral anticoagulation. So the standard regimen requires about 45 days of oral anticoagulation post-procedure, followed by antiplatelets. DOACS have been shown to be as effective as warfarin, and the procedure itself is non-inferior to warfarin for stroke prevention, with obviously significantly lower rates of major bleeding, hemorrhagic stroke, and mortality. Now, landmark trials suggest good success rate, low complication rate. What about older adults? So there is some data in older adults already. And what I would leave you with is that the data is showing that there are higher rates of major adverse events with the Watchman in those 80 and above versus those less than 80. But when we really look, it's showing that females, those with congestive heart failure, those with diabetes, those with renal disease, those with anemia, and those with dementia have significantly higher risk of major adverse events. So I think this is really showing us multimorbidity. And we know that our females, there is a sex-specific difference in frailty, and females are at a much higher risk of frailty as opposed to males. So this may also have been pointing out frailty, as frailty was not investigated in this first trial. The second trial just published and in press now of Medicare beneficiaries investigated frailty, an outcome after the Watchman, found frailty was present in 50% of their population, just about, high risk frailty in 16%, just about. And it was this high risk frailty that predicted poor outcomes. So prolonged hospital stay, 30-day readmission, 30-day and 1-year mortality. So again, just showing this is a good option in older adults, but patient selection is key. So just to finish with our case, we had an 89-year-old with AFib and all of the classic CHADS2 risk scores. So obviously at high stroke risk, a lot of comorbidities, which we just learned about was a marker of risk of stroke, risk of bleeding, risk of mortality. And she has mild cognitive impairment. So she does have a risk of medication non-adherence. She's quite functional, and she has good supports at home, which is always helpful. She had syncope and a fall. So she had a fall due to syncope, and presumably this fall risk was reversed with her pacemaker. She had a moderate to large subdural, but this was traumatic in nature, and it is not predictive of future intracranial hemorrhage recurrence rates. And this was all on warfarin, which we know we can lower her future intracranial hemorrhage bleed risk with a DOAC. And lastly, when I went in and talked to her about her own values and preferences and fears, she told me she feared stroke. She saw her brother suffer from a stroke. He was reportedly never the same, had poor quality of life, and in her mind, suffered until the end of his life. So patient priority here was avoiding stroke. So after this discussion, alongside her son and daughter-in-law, we did start the patient on oral anticoagulation, started her on EDOXABAN 30 milligrams daily instead of warfarin. We wanted the DOAC to lower the intracranial hemorrhage risk. Apixaban and EDOXABAN, in my mind, have the best evidence in older adults. We did opt to go with a once daily dosed drug to aid in medication adherence, and the only option then would be EDOXABAN. And because of her creatinine clearance of 40, we did dose reduce appropriately our EDOXABAN from 60 to 30 milligrams daily. Neurosurgery suggested we restart at about the 4-week outpatient CT head as long as there was stability, which there was, and the patient is about 1.5 years out now and has tolerated the drug very well so far. So I think to take home, treatment of atrial fibrillation in older adults is difficult. They have a high stroke risk and a very high bleed risk. But randomized controlled trial data and real world data really do support efficacy and safety of DOACS in older adults. They are at least as effective and at least as safe, if not safer. And overall, I would suggest apixaban and edoxaban have the strongest evidence of a safety and efficacy in this population. Due to the age-related risk of stroke, rarely does the risk of bleeding outweigh the benefit of oral anticoagulation in this population, yet it's underprescribed. It is not without risk, and I don't think we should take the decision lightly, and the decision needs to be individualized. So think about your patient as a whole, think about frailty, multimorbidity, polypharmacy, and if you're uncertain about their cognition, about their function, about their frailty, consider collaborating with a geriatric expert, and then take into account risks, benefits, current literature, patients' values and preferences, and come to some decision based on shared decision making. If your decision is made to start anticoagulation, just decide on that once versus twice daily dosing, dose reduce only if indicated. Consider whether they have polypharmacy and drug-drug interactions and whether you should change the dose of the drug based upon that. And think about whether they do have contraindications to oral anticoagulation. And lastly, if they're unsuitable, consider edoxaban 15 milligrams daily or referral for left atrial appendage occlusion if you think they're suitable. Thank you so much.
Well, thank you very much, Dr. O'Neill. So there's a couple of questions here.
Yeah.
Now, just one thing that I want to add is that, we do the left atrial appendage occlusion devices here, and we've had a few sent from Edmonton to our center. So that would be Dr. Wilton, Dr. Kuryachan, myself, Dr. Bisios, and Dr. Sakadina. So we have a combination of an interventional cardiology and EP team that are doing those. So this lady could have been a potential candidate for that.
Agreed.
And I think that would be something that could also have been discussed. So there's a question on any evidence to help guide management of elderly patients at higher bleeding risk requiring dual antiplatelet therapy after stenting. For example, Plavix plus DOAC.
Unfortunately, even in all of the trials that were done looking at dropping aspirin and double therapy versus triple therapy, the percentage of older adults in all of those trials was around 1 to 5%. It was very, very low. So it's really difficult to pull out data and do a sub-analysis on anything with that low of numbers. So really, we are kind of in a evidence void area there, and we just try to do what we can to decrease bleeding risk. So when I look at the data, I look at the apixaban and edoxaban trials for triple versus double therapy. And really, edoxaban looks like it is non-inferior to triple therapy, whereas apixaban does look to have lower bleeding rates. So if I'm being honest, I actually think apixaban probably has the greatest data for older adults that require antiplatelet and oral anticoagulation. Of course, I lower the duration of and dual the Plavix preferentially to the lowest amount of time possible. I use Plavix over ticagrelor if at all possible from a thromboembolism or from a atherosclerotic kind of burden perspective. I always try to use Plavix because of the lower bleeding risk. And really those are kind of my preferences. So I lean towards apixaban, shortening my duration of Plavix to as long as I can and choosing Plavix over ticagrelor to lower my bleeding risk.
Dr. Kavanagh has a question.
Deirdre, I really enjoyed your talk. Thank you very much.
Thank you.
I was just wondering about your statement that females greater frailty risk than males.
Yeah.
Assessed, and is there something we can do to change that?
And that's a very good question. So right now, the pathophysiology of why females have more advanced frailty is not certain. I mean, obviously we have a longer lifespan and we have a longer duration to accumulate all of these deficits, and those could be why we're finding that females have more frailty than males. And we still have better resilience overall because we still have decreased mortality versus males for whatever reason. But at this point in time, we don't have great high quality literature on how to prevent frailty. What we do know is in that pre-frailty phase, if you have a multidisciplinary exercise intervention and protein supplementation both, that is what is suggested to be the best intervention to reverse frailty. We do not have any evidence that we can reverse frailty once they're frail, but pre-frailty we can reverse to non-frail, and frailty we can plateau with the intervention of exercise and protein supplementation. So I usually talk to my patients, try to get them to join cardiac rehab if I can, just because it gives them a little bit of motivation and safety to start exercising again. And then if I can get them to do that, then I also talk to them also about supplementing their protein intake. A lot of older adults don't have the same hunger cues, and it's harder to cook proteins than it is to cook, some toast and soup. So I just talk to them about their diet and where we can increase protein intake when possible.
Thanks.
So how about bone density? Is that a marker of falls and frailty? And can we use it to guide therapy in atrial fibrillation in these patients?
Definitely a marker of fall risk, but so far has not panned out as a marker of frailty. So, I mean, I would again take it into account in your multimorbidity and all of that picture, but more so I would rely on functional assessments of frailty. If they can get up in their chair 5 times without using their arms, they're pretty robust. If they really struggle to do that, then that's more an indicator of frailty. We don't need to be doing, I love doing full comprehensive assessments of frailty. I think that's the best way to measure frailty, but even doing something is better than nothing. So watching them walk into your clinic, seeing how fast they walk, if they're very, very slow and hesitant on their feet, that in itself tells you something about frailty. If they really struggle, like I say, to get out of the chair 5 times, that tells you something about frailty. So as good as a full comprehensive assessment is, I know it's not rational in a normal cardiology clinic where you're trying to get patients in and out the door, but there are little things that you can do to just get a bit of extra information on your patient, and maybe even just that is enough to refer them on to somebody else in regards to a full assessment of frailty.
Dr. Lyons has a question here, and is there a certain frailty score you would suggest for women over men?
Yeah.
For example, are there certain scores that may be biased when it comes to assessing women?
Yeah, at this point in time, I do not have a score of preference for women over men, unfortunately. I often use the Edmonton Frail Scale. I think it is a well-validated score in a lot of areas, but including acute coronary syndromes and heart failure. So I do use that score often for both my males and my females. And I also use the Freed Frailty, 5-point scale, just because that score is really prevalent in the literature, well-validated across the board. And I think that its ubiquity in the research really makes it more practical to use, because you can kind of apply your results to the literature in that way. But really, there is still no consensus on what frailty score we should all be using. There is no gold standard. There's still the debate in the high up frailty experts on which frailty theory even is better than the other, because there are 2. So I think it's going to be some time before we establish which frailty test is best. The best thing I would recommend is look for something validated in your area, but something that's practical to use, get to know it well, and use that. In TAVI, for example, the Essential Frailty Toolkit by Jonathan Affolalo at McGill is actually super easy. It's not a comprehensive frailty assessment, but it is a marker of frailty associated with outcome in TAVI and SAVR. And all that it entails is some cognitive screens, such as the mini cog and the chair raises that I was talking about, the 5 chair raises, as well as a hemoglobin and an albumin that you have in front of you on the computer. So pretty quick, pretty easy, and validated in TAVI and SAVR to predict outcome. So I try to look for something validated in my area, quick and easy to apply universally, and use that because there is no gold standard for frailty assessment universally or in males versus females, unfortunately.
Well, thank you, Dr. Neil. That was a great review.
Yes.
You highlighted the fact that the net clinical benefit still outweighs
Yes.
any risks, that, we should anticoagulate elderly at high risk with no hesitation. Of course,
Absolutely.
keep in mind everything you taught us today. Well, thank you very much, and we'll be in
Thank you.
touch.
All right. Bye.
Bye now.